Good afternoon, everyone, and welcome to the webinar, Monitoring Clinician Burnout at the Organizational Level. My name is Molly Meinbrust. I'm the Associate Director of NHSC Educational Programs at the Association of Clinicians for the Underserved, and I'll be your moderator for today. Feel free to type your name and location in the chat so we can see who's here today. We're so happy that you all have joined us for today. This is the 7th webinar in our 2024 National Health Service Corps Empowerment Initiative, Advancing Clinician Wellness and Health Equity. As some of you may know, this HRSA initiative was designed to help NHSC participants and new clinicians in the field prepare for serving in health professional shortage areas. We have also designed some of our webinar series and resources for the leadership and administrative staff at NHSC approved sites, like this webinar today on monitoring clinician burnout. You all have the power to change the culture, work environment, and organizational practices that can support clinician wellness. We're so happy you're here to learn how to do just that. During our last webinar, we talked about how clinicians can use burnout assessment tools to see if they might be experiencing burnout and to better understand the severity of and potentially the causes of their burnout. We explored 7 validated burnout assessment tools, tested using one together, and talked about how to interpret scores and how to begin addressing burnout. If you missed that session, you can find the recording and slides on our webinar information page. Now, since we know that burnout is a workplace phenomenon and stemming from unresolved issues at the organizational level, we wanted to make sure we're also helping NHSC sites understand how to measure and address burnout among their clinical workforce. We're starting that work today with this webinar, and later in the summer, we'll have a series of webinars on fostering resilience at the organizational level, where you'll learn about organizational practices and policies that can help create a supportive, efficient, and healthy environment for clinicians and for other employees. On that note, we're really excited to have Dr. Marcqwon Daywalker back to share his experiences and expertise with you all addressing burnout. Some of you might remember him from last year when he presented a grand rounds on personal and organizational strategies for addressing clinician burnout. Dr. Daywalker is an integrated family medicine physician serving as the Chief Health Equity and Wellness Officer at AccessHealth. As an executive physician, he implements multidisciplinary, trauma-informed community medicine approaches to address the quintuple aims of healthcare: health equity, improved patient experience, improved outcomes, enhanced clinician well-being, and cost reduction. During the height of the COVID-19 pandemic, and while he was still an NHSC scholar, Dr. Daywalker helped implement programs at AccessHealth that decreased burnout and increased well-being for health center staff. You'll get to hear him talk about this work later on in the presentation. Dr. Daywalker is also a faculty member and health center coach for the National Network of Oral Health Access, Integrating Diabetes and Oral Healthcare Collaborative. He co-chairs the American College of Lifestyle Medicine Federally Qualified Health Center Group and the Association of Clinicians for the Underserved Justice, Equity, Diversity, and Inclusion Committee. In addition, Dr. Daywalker serves on other state and national committees to improve healthcare services and has been a speaker at many state, national, and international conferences. He received his medical degree from Morehouse School of Medicine, where he received the institutional honor of the Primary Care Award. And when he was a National Health Service Corps scholar, he was elected to become a participant in the ACLM National Health Equity Achieved through Lifestyle Medicine 2022 cohort. Welcome, Dr. Daywalker. We hope you all learn a lot from him today. I'm very inspired by Dr. Daywalker's work, and I know you all will be too. There will be plenty of opportunities to engage with Dr. Daywalker today and fellow attendees throughout the presentation, through polling, the chat box, and maybe even raising your hand to speak. So please make use of these opportunities to interact with one another today. Before I hand the mic to Dr. Daywalker to get us started, I'd like to go over a few housekeeping items. We did recently switch webinar platforms from WebEx to Zoom, and we hope this provides for a better experience for you all. Do bear with us, though, if we encounter any tech issues as we get used to Zoom. This webinar is being recorded, and a link to the recording will be emailed to you within 2 days. The PowerPoint slides for today can be found on the webinar registration page, which we'll link to in the chat, along with a direct link to the slides. If you missed any of our previous webinars, you can find the webinar slides, recordings, and transcripts on that same webinar information page. We'll have time for Q&A at the end of the presentation, and we'll also ask you some questions throughout the presentation that will hopefully spur conversation. Please type any questions you have in the Q&A box, which is separate from the chat box, and it can be found at the bottom of your screen. If you have a technical assistance question, contact our colleague Josh. He's putting his contact info in the chat now. Polling will be used throughout the presentation using the Slido platform. You have two options for responding, and this is a little different than when we were using WebEx in the past. So again, bear with us with this change. But the first option is to take a picture of the QR code on the slide, and we'll practice that one now. We've got a question about your role related to the NHSC. So again, you can take a picture of the QR code with your cell phone and enter the password provided. That'll take you to the Slido website. You can also manually navigate to that Slido website, enter a numeric code and then a passcode. It's all on the screen here. Once you open Slido, it will automatically update with the next polling questions as long as you keep that window open. So we do hope you all use it today and participate in our polling. And as in WebEx, the polling questions will not pop up in the Zoom webinar like they did with WebEx. So you will have to make that extra step, but we'll be very patient with you all today as we wait for you to respond. And I see some responses coming in, so that's great. Thank you. Finally, we would really appreciate your feedback on today's session. So definitely complete our survey at the end of the webinar to let us know how we did and how we can improve our trainings. To see closed captions, click on the CC icon, the bottom of the webinar window. And with that, I'll hand the mic over to Dr. Daywalker to begin our presentation. Thank you.
Thank you, Molly, for that wonderful introduction, and good afternoon, everyone. Really excited to speak about this topic, something I'm really passionate about. And I see the responses coming in right now. And so the first question is, what is your role related to the NHSC? And right now it seems like it's 45%. We have people here that's the site point of contact, which is awesome. We have some C-suite leadership, so really, really great to see that. And we also have scholars and participants, site staff as well. So I think we're going to have some very fruitful discussion when we get to the point where we have some questions here, and we'll go ahead and move forward. I think we have a few more. Oh, go ahead, scroll on down, Molly. We have middle management, really important. Awesome. Okay, let's go to the next question here. I think we have a couple of questions here starting off before we get to content. Oh, no, learning objectives. So our learning objectives today is, number one, we want to understand the importance of monitoring clinician burnout. Secondly, we want to explore factors to consider when utilizing burnout, assessment tools to measure burnout among our workforce. Thirdly, we want to learn about a few validated and commonly used burnout assessment tools. And lastly, we want to be able to discuss strategies and resources needed for implementing a burnout assessment tool within our organizations. There is the poll. So this next question here, you guys, is, does your organization monitor burnout among clinicians? So take a few seconds here and let's see where everyone is at. All right, so it seems like we have nearly an even split between having plans, not doing so currently, and yes, which is great. We're all at different stages of monitoring burnout, and it's something that we know is definitely important, and we're trying to figure out the best way to do that. So that is well. And here's our next question. If your organization does monitor burnout, how do they do it? One-on-one supervision, team meetings, regularly conducted surveys with staff. Great. And it looks like right now what's prevailing within our small group session here is the one-on-one supervision, which is really, really important. What we have learned and what we know, a lot of things that determine how our employees and staff feel about our organizations sometimes directly mirror that supervision that they have with their director, supervisor, management. So that's really important that it's being evaluated on a one-on-one basis. All right. And I think this is our last question before we get into content. If your organization uses assessment tools or surveys to measure burnout, which ones do they use? And Molly, I'm not seeing the percentages here.
Um, so this is one where it's open text, so folks are typing in their
Perfect.
answers
Okay.
here.
Got it. I
Okay.
see up top now.
Okay.
All right, the mini Z. That's one we're going to be discussing. No assessment tool. That's okay. Someone else says, I don't know. Maybe that's I don't know which one we're using, but we're using one. But that's all well. We'll be able to discuss a few different ones here during our time together. All right. So why is it important to monitor burnout? Inherently, we know this, but we really want to harp on the idea that it's really important for us to understand how our clinicians are doing. And not only on an individual level with our clinicians, but really and truly across our organization. Many of us serve in capacities within the organizational structure where we have multiple clinics, multiple departments, and there's a lot of different things that happens in and outside around the communities that we serve. So before and after a crisis is also important. It's really important for us to identify and pinpoint what are the direct causes of burnout. It could be individual level. It can be, well, individual level can feed into what the organizational structure and culture may be, but figuring out what those endpoints are that's causing burnout. It's also important being that it helps us guide to solutions to addressing burnout. Another thing that's really, really important for providers and clinicians is this allows us to show that we truly value them and the work that they do, especially in the spaces that we work in. We understand that oftentimes that um, sometimes our colleagues and physicians can feel overburdened with the idea of having a lot of work and maybe not feel like they have all the resources for their patients. So this is a way to kind of show that we really appreciate the work that they do. And lastly, of course, which is paramount to what we do in the community health center space, is that it ensures a certain level of quality care that we're delivering to our patients. The old saying goes that if you don't have anything in your tank to give, your work is going to definitely reflect that. So we want to make sure that we pour into our providers so that they can actually pour into our patients as well. So there are different approaches to monitoring burnout, as we just elucidated with the questions that we had. So we can certainly do it one-on-one supervision that's always happening. We always have our check-ins with our manager, our director, our chiefs, where you have that where they check in and see how we're doing. We also have our all staff meetings, whether it be through a town hall or whatever the case may be, certainly within departments. I know within the family medicine department, everyone that participates within the family medicine scope of practice across different locations, we come together and we have meetings. Also too, maybe with your individual team, maybe you're a manager, maybe you're a physician, but we have smaller sub teams that we meet with. And that's another approach to monitoring burnout. But specifically what we're going to discuss during this hour that we have is measuring burnout of our workforce using assessment tools. So selecting the appropriate tool, there's some things to consider. So considerations for choosing a tool, we want to really be thoughtful about what exactly is it measuring. There's different dimensions of burnout. So that's something that we want to go in eyes wide open, thinking about the intentionality of the tool that we're choosing. Also, we want to think about the importance of the dimensions of well-being and how it affects different stakeholders. And what we mean by stakeholders here is that there's many different people that have some type of input, throughput, or output as it relates to our community health centers. We have a board of directors, we have our C-suite, we have our middle management, we have our providers, we have our non-clinical staff, we have our patients, we have leaders in the community, right? We have the community as a whole. So it's important to think about the dimensions and how it relates to our stakeholders. We also want to think about the respondent and the organizational burden. Like, is it something that's really feasible or realistic for us to implement within our community health center? We also want to think about how actionable is the data. So when we get back these results, what is our best next step? Are there any steps that we can realistically take? We also want to think about that sensitivity to change, the idea of getting back that information and, over what time span can we actually lead to some type of significant improvements in the measures that we're looking at. We also want to be very mindful of the validity of the findings. Is this resource that we're using accurate? Are we getting back really clear data that allows us to know that this is a true result or finding that we get? And also, too, we want to think about the applicability to our workforce. Because there's different tiers or different things that people do within the healthcare setting that we work in. We have community health workers, we have social workers, we have physicians, we have front desk folk, and they all have a different scope of practice. So not every assessment tool may be applicable to the workforce. So more about selecting the appropriate tool. You want to determine what you want to assess. Again, dimensions of burnout and related measures of health and well-being. You can look at burnout itself, fatigue, workplace engagement, emotional health, quality of life, professional fulfillment, and satisfaction. Again, you want to involve stakeholders, determine which dimensions to assess. You want to bring in the organizational decision makers, clinicians, our patient advocates, as well as others within our community health center. And you also want to consider, especially being that sometimes the workers in this space, we all wear many different hats. We have many different responsibilities. So we want to make sure that we're really mindful of our respondents and the organizational burden with completing these assessments. In regards to length, how many survey items or questions does the tool have? Is there a cost, right? You got to think about the bottom line in terms of anything that we do within the health center as well, to use the tool or even get the results. You want to think about the complexity of the analysis. How's the scoring really completed? Does any of the questions have reverse scoring? Is there an overall score, or are there individual dimensions scored separately? Are the cut scores provided, so on and so forth. In regards to sensitivity to change over time, you really want to look at the timeframes used in the assessment tools regarding experiences of burnout. Some tools may ask about, have you experienced burnout in the last 2 weeks versus 30 days? Some may not refer to any timeframes at all. And you would also want to think about, are you trying to look at changes of burnout over time, or are you trying to get a cross-sectional view of what's happening? Back to the different stakeholders, you want to think about, who is the tool truly designed for? Are we trying to focus this particular assessment to start off, for this next current one coming up, to focus on healthcare professionals, on any specific type of provider? Maybe it's just your physicians. Maybe it's anyone in the helping profession with clients, patients, or our consumers of the community health center, or any occupation. So here are some examples of some validated tools. So you have the Maslow Burnout Inventory, the MBI. This particular tool is for all occupations, and there's different versions available. It consists of 22 items, and the measures or outcomes being evaluated is emotional exhaustion, depersonalization, and personal accomplishment. All three of those things universally kind of make up burnout. The cost for this particular tool is $15 per individual, and there is no time frame associated with this one. And there's different versions, as you can see that we have listed here, the MBI for Human Services and the MBI HHS MP. All right, so some sample survey items. So for the emotional exhaustion, just for an example, you'll see that question number 1, it speaks towards feeling of being emotionally drained from work. Or you can see number 20 within this assessment for personal accomplishment. I have accomplished many worthwhile things in the job. And the response options for this particular tool is from 0 to 6, 0 being never, 6 being daily. And in terms of scoring, for burnout, a score greater than or equal to 27 is emotional exhaustion. A score greater than or equal to 10 is depersonalization. A score less than or equal to 33 is towards a personal accomplishment. So you want to be able to evaluate the results to see if they're positively or negatively correlated, and you'll see that coming up. So the 5 work experience profiles based on scores from the MBI, you have burnout, the negative scores on exhaustion, cynicism, and professional efficacy. Another profile would be overextended, which means having strong negative score on exhaustion only. Ineffective relates to strong negative score on professional efficacy only. Disengagement, strong negative score on cynicism only. And then you have engagement, strong positive scores on exhaustion, cynicism, and professional efficacy. So just different ways to break down and convey the numerical number into what is actually being expressed in real time. And then we have the mini Z survey, and I believe someone said that they used the mini Z 2.0 within their health system. This one is also for any occupation, and there's also different versions available as well. This one is just a 10-item survey. It measures the supportiveness of a workplace environment, the work pace, and EMR stress. This one is also free. No time frame is used here. You have different versions. You have the mini 2.0 and the mini res. So with the mini Z survey, unlike the MBI that goes from 0 to 6, this one goes from 1 to 5. So 1 being, I feel completely burned out. I'm at the point where I may need to seek help. 2, being that the symptoms of burnout that I'm experiencing won't go away. I think about work frustrations a lot. 3, I am beginning to burn out and have 1 or more symptoms of burnout. An example of this is emotional exhaustion. 4 is I am under stress and don't always have as much energy as I did, but I don't feel burned out. And 5 being I enjoy work. I have no symptoms of burnout. So this is a little inverse to what the MBI is, the scale. The higher you are on this scale is more positively related to your work, versus the MBI. The higher you were on that scale, the higher your feelings around burnout, cynicism, emotional exhaustion was. So next is the ProQual, which is the professional quality of life measure, which is one of the assessments that we leveraged and utilized within our workplace. And this audience for this assessment is anyone working with individuals who have experienced extremely stressful events. The items here are a total of 30. And what it measures is compassion satisfaction and compassion fatigue, but compassion and fatigue being broken further down into burnout and secondary traumatic stress. It is also free, and the time frame is over the last 30 days. So the measures here, just a sample surveys item. So number 4 within this assessment is I feel connected to others. For example, number 26 is I feel bogged down by the system. The response options are from never to very often. In terms of burnout level, the score less than or equal to 22 is low. Score from 23 to 41 is moderate. The score greater than or equal to 42 is high. So some considerations for implementation. Confidentiality is a huge consideration, and especially in the space where we're thinking about people and their feelings around the work that they do or their workplace environment or has anything that may allude to mental health is really, really personalized for people that are filling out this information. So there's things that should be considered, such as inclusion of demographic items that could allow or disallow the identification of individuals. Implementation and analysis by external organization like an academic institution might provide an extra layer of confidentiality. Data certainly should be de-identified and aggregated. And you want this work to be anonymous. And there's a thought and there's a potential drawback to anonymity because it limits direct assistance to maybe the people that need it. But given how personalized the information is, it's just something that you want to, really critically think about how we administer these assessment tools. So some additional considerations is undermining trust. You want to make sure that we only ask about topics that the organization is truly willing to address. We really want to avoid diagnosing staff. We want to ensure that employees' results will not negatively impact their employment. And we also want to think about potential misuses. Simplifying assessments by removing certain dimensions may lead to invalid results. Arbitrarily assigning ranges of burnout also doesn't really give you a valid set of results as well. So with that, we have another question here. What resources does your organization have for implementing? And Molly, I'm having trouble reading words here behind my.
I got you.
Okay,
What
perfect.
resources does your organization have for implementing an assessment tool? So for
Okay.
example, funding, staff availability, partners, etc. So this is an open text one, so folks can fill in what they've got at their organization. And I see someone typing now.
Okay, perfect. Yeah, and I was able to move that dialogue box.
Oh, okay.
Perfect. So yeah, we have a couple people typing here.
And we're doing great on time.
Awesome. Staff availability, we need additional funding resources. Okay. So an opportunity here. I chair the quality management team and we're interested in measuring this area. Awesome. Awesome. All right. So I think that we have some things that we can discuss here a little bit later. So we'll go ahead and move forward with the next slide. Molly, I may be okay, here we go. Who should be on the survey implementation team? What are you guys' thoughts? Who should be a part of this brain trust? Chief Medical Officer, since I'm here. Absolutely. We love our chief medical officers and they absolutely should be at the table. Medical directors, human resources, absolutely. Someone from each group. I love that. That's really important. Top management clinicians. Okay. All right. I agree with everyone in this active poll here. And we'll talk more about that coming up. Okay. What staff or leadership buy-in will be necessary to succeed in implementation? What do you guys think? As many as possible, team effort, interdisciplinary approach, cross-sector collaboration. Absolutely. I agree. It will take buy-in from our clinical staff who will likely view this survey as just something else to fill out. Agreed. Absolutely. There's often an initial negative financial impact of making changes that are burnout. The organization has to be prepared and accepting of this. I want to hear more about that. I love that insight. I love that insight. Oftentimes, we think about or discuss the short-term quarterly view of results versus that long-term impact. And sometimes, yeah, there's a short-term hit to get the greatest impact overall. So I wonder if that's where you were kind of going with that. So we'd love to discuss those things a little bit more.
And Dr. Daywalker comment
Yes.
came in that assessment without implementation plan is simply busy work. It came in the chat.
Got it. Absolutely. I agree with that as well. I love these insights. Really great insights. All right. Molly, I don't know if it's my computer here that has a little bit of a lag or. Okay. Interpreting results. Molly, can you hear me?
Yes, and I can help with the slides if it's not working.
Okay, perfect. Let me see. I think we're back online. Here we go. So what do you do with your survey results once you have them? So we will want to share our results with our clinicians and help them understand the scores. We would like to be transparent about plans to respond and elicit input from our clinicians. We want to implement low-cost, low-barrier interventions when appropriate or in emergencies. And we would like to update our clinicians to know when actions are need to be taken and address results. And also too, because it's a continual process, we always want to request feedback. So some questions that we might ask when interpreting results include, where are you seeing the highest levels of burnout? Are certain disciplines or departments struggling or thriving more than others? What dimensions of burnout are impacting clinicians the most? And what factors are contributing the most to burnout? So as we get our results, suffice it to say, it's not just enough to see that number or that range. We have to critically think about how do we make sense of the results that we've gotten. Uh-oh, did we skip one? Okay, Molly, I might need your help. There we go. All right. Some more questions to consider. What organizational practices and policies can be changed to mitigate burnout? What new interventions can be implemented to address clinician well-being? What interventions can be implemented right away to quickly reduce stress on clinicians, especially in a crisis scenario? I think we all went through the COVID-19 pandemic and understand and know that crisis is something that cannot really be planned for, but we have to figure out ways to support each other as we go through crises. So we want to make sure that we think about those as well. So next question, what resources does your organization have to address the findings of the assessment? And what partnerships can be used to address staff needs? What are our thoughts here?
While folks are chiming in, Dr. Daywalker, I wonder if you could speak more too about the buy-in piece. In your work, have you ever encountered challenges getting buy-in from clinicians in this process? And could you speak to that?
Yes, absolutely. So buy-in is so important. And principally the way I think about buy-in is that, yes, you have your organizational decision makers that can, have the resources, the will and want to implement. But the only way that sustainability is created is that the participants, whether it be we're talking about clinicians here, front desk staff, you name it, if you don't have buy-in, it's impossible to have sustainability or good quality from what you've implemented. So you want to think about ways that first and foremost, you have their engagement from the start, especially having them or helping them identify if it's even a need or a desire. So having them at the table, even in first discussing what something may look like is really important. And once you have that, then you truly have some buy-in because they really feel included. So that's the way and the steps that we took in terms of even starting to consider an assessment. We reached out from an anonymous standpoint in terms of getting feedback, asking what was needed, right? Is this something you guys would be interested in? What could this look like? And that led to tremendous buy-in. Hope that answers the question there for you, Molly.
Yeah, that's great. And I know that one of the causes of burnout can be lack of control and decision making in an
Absolutely.
organization. So yeah, that's great. Okay,
Absolutely.
looks like we got an answer come in.
Okay, awesome, awesome. So we have set aside funding for initiatives from staff dinners to team building outings. Awesome. We've partnered with a meditation center to teach team members to meditate. I love it. I love it. I love it. Okay, thank you for sharing. Very good. We'll go to the next slide. Oh, we have one more person typing. We'll give that person some time here. HCCN partnerships with objectives to reduce clinician burnout caused by digital tools such as the EHR. I love that. I love that. I love that. We'll talk a little bit about HCCN and partnerships and things of that nature when we get into the case study. Love it. Love it. Love it. All right, Molly. Okay. Case study. Molly, I didn't skip anything there, did I? I think this goes right into the next case study.
Yep.
Okay, perfect. So our case study, we have Dr. Richards, PhD, physician assistant, also a former NHSC loan repayment program participant. And he shared his experience, knowledge, and expertise with us in terms of ethical use of well-being assessment tools. In a direct quote here, I just want us to think about and how it may be applicable to what we're discussing in terms of doing a burnout assessment. But from a clinician lens here, we have a quote saying that reads, "Don't order labs for a patient if it doesn't change the treatment plan. It will only injure the patient." And as we sit with that and think about that for a second, is that I think the correlate here is that as we think about workplace or workforce development or wellness or burnout, we really don't want to assess or look for things that we have no plan or intention on actively and in a continuous ongoing way addressing burnout, the wellness or well-being, right? And to give a little bit more context regarding Dr. Richards here, what he noticed within his organization is that burnout was something that was being assessed and talked about, but the interventions were not directly linked in a way that would help with burnout. They had ice cream socials or things of that nature, but it really didn't get to the root causes of what led to burnout in his setting. So here, furthermore, it's kind of mentioned here. So without effective solutions, clinicians will become more burned out, right? So just kind of, masking or trying to stretch out, through yoga, burnout, may not be the way. So he also has some insights of making sure that clinicians were involved from the beginning, something we've kind of discussed throughout this hour. And then also lastly, you just really want to ensure that psychological safety is paramount so that clinicians can actually get the help that they need. And the reason why this is really important from a clinician standpoint, in terms of maintaining our boards and things of that nature, there is a little bit of a stigma or concern as it relates to a physician's mental fitness to be able to perform their jobs. So just having someone sit down that may be feeling burned out to do an assessment and release that information within itself can be a little distressing. So we just want to make sure that if we're screening for these things, that we have a good plan in place, that you have the buy-in so that you can be effective with what you're trying to screen for and ultimately have some really good interventions around. All right, our next case study involves my experience with my community health center starting at AccessHealth here. And now how much time do we have? It's 42. So when I first started here within my community health center from residency, actually, um, literally within a couple of months, we had this thing happen. January 2020 called COVID, COVID-19. And what I happened to notice is that a lot of my colleagues, including myself, were extremely distressed. We had no idea what the virus, behaved at that time truly. What we knew is what the news was giving us. The CDC really didn't have great recommendations at that time. Um, but I reached out, I advocated, even as a new attending, to our CEO and just said, hey, I'm noticing this amongst staff, other providers, and we were looking to do something within trauma-informed care in terms of organizational transformation. So I had the ideal of really pivoting a little bit from just thinking about a trauma-informed lens for our patients, but also having a trauma-informed lens for our employees. So that ended up leading to meetings with my CEO and essentially advocating for a position where I became our director of health and well-being. We hosted town halls about burnout and had questions around COVID-19 to kind of help with some of the preconceived notions around it, the vaccine when that was happening. We also leveraged an anonymous feedback survey tool for staff where those results came directly to myself and the CEO. And we sat down and we tried to figure out how we could intervene. We provided many self-care resources. And so we measured burnout across our agency. So we partnered with the University of Texas, the School of Public Health, in creating a survey that consisted of the ProQual the World Health Organization it's called the Q5 Wellbeing Index through the World Health Organization, the Gratitude Objective Checklist, as well as other questions around coping and workplace environment. We partnered with our state primary care association that really administered the survey itself. And our funding came from our HTCN that partners with our local state primary care association. And the last piece of it, we also partner with a total worker health specialist through the that is essentially funded through the CDC and the National Institute of Occupational Safety and Health. So a total worker health expert from UT to help us with guidance in terms of some of our interventions. Current updates for our continued wellness efforts. We have really great outcomes from listening to our workforce, engaging them, implementing those interventions, and had some really great results from those surveys, those assessments that we mentioned. And leadership felt it was something that they wanted to further expand upon. So we created a executive role as where I currently serve as the Chief Health Equity and our Wellness Officer. So we really wanted to pivot from crisis mode and just being responsive to actively doing prevention and promoting health and well-being. So we currently do some lifestyle medicine interventions for our workplace and workforce that also has trickled down to our patients as well, where we're really using that trauma-informed lens and human-centered approach for patients and shared medical appointments. So that's kind of what we're doing now in terms of how this trickled down to being a strategic focus within our organization. So some recommendations that were created from a lot of this work was to advocate or create a wellness officer role to champion for wellness for clinicians and other employees. Just have it really baked into a part of what the organization does from a strategic planning perspective. Another recommendation is to regularly measure burnout and other areas of well-being among your workforce, again, using some of the validated assessment tools that were mentioned here during this webinar. We want to make sure, again, that you include relevant stakeholders in choosing these tools. We want to secure resources and identify partners to implement assessment tools and analyze the results. We want to ensure confidentiality of employee responses. You want to share the results with your employees and make sure that we seek their feedback. And you want to co-create these plans to address the results and respond to any suggestions that our employees may have. Some more recommendations here is that we want to provide some regular opportunities for that two-way communication between leadership and clinicians regarding well-being, challenges that they found in the workplace, and suggestions for improvement. Continue with the staff and department meetings, clinical rounds, one-on-one supervisions, maybe leveraging the use of an anonymous feedback tool. Want to continue to provide our mental health resources for employees and encourage their use. Implement evidence-based practices to support clinician well-being and improve workplace efficiencies. And of course, our last recommendation here is to make sure that we continue to join the upcoming webinars that are coming on fostering resilience at the organizational level to learn more. And some additional resources from the NHSC Empowerment Initiative. There's our guide for checking in and seeing how our clinicians are doing. And our infographic about clinician burnout and what are those contributors and consequences of those. And we'll pause here to see if we have any questions or comments from today's webinar. I think we have about 10 minutes here, Molly, which is really, really encouraging.
Yeah, thank you, Dr. Daywalker. That was a great overview. I know it's a short webinar and there's a lot more that could be said around this topic. So I do hope folks join us for future webinars. But it looks like, oh, there's a question about getting the slides. And yes, if Josh, you could post the link to the slides in the chat again, that would be super useful. They are up on our webinar information page currently. So one question I have for you, Dr. Daywalker, is can you speak more about some of the interventions that you all ended up implementing after you did your town halls, learned, got feedback from your anonymous feedback practices, and then also, after measuring burnout among your workforce, what interventions did you all take on? Were you able to do?
Yes, so I love that. One of the things that we noticed was that our our employees, although we had the EAP, the Employee Assistance Program, where they could, reach out and check in on their like mental health and things around that. There wasn't a lot of comfortability around that. So we were able to partner with an external virtual um, mental health like therapy group. And they came in, we actually did a town hall with them to kind of have a little bit of a warm handoff to let them know that, hey, this is external to us. So we offered that to our employees as well as their significant other. Um, because during that time, again, we were dealing with really around the height of the COVID-19 pandemic. And we knew or understood how much having protective factors such as family and having them feel well could ultimately kind of help our employees and, part and parcel of our organization as we supported our patients, as we kept our doors open.
And there's a comment in the chat that Al Beller, they were recently able to get funding for a clinical EHR specialist role to assist with templates, tips, etc., to assist with EHR documentation for providers. And that has been very well received.
That is amazing. And that speaks to the many different inputs that go into somebody's overall wellness, well-being, which directly impacts burnout, right? Including culture, right? But there's so many different things. It could be that workflow needs to be addressed. Structures around work may need to be addressed, like this EHR, templating, and things like that. Maybe there's something going on from a cultural perspective that we really should think about how the climate of our organization is moving and how that may affect our employees' morale. It could be one-on-one supervision. There's a lot of things that go into someone's overall experience of how they perceive the work that we're doing. So that's why it's really important to be able to pinpoint exactly what level should we address our interventions.
Thank you. And I wanted to add too that I know in the literature, it shows that adding scribes really can help reduce burnout amongst clinicians. And of course that there's a funding component there to get scribes, but it can really help reduce the amount of work for the clinicians. Just want to make a few notes. We did go ahead and open up the evaluation poll so folks can start filling that out before you leave. But we have another question for you, Dr. Daywalker. Could you provide some info on the size of your organization and how you funded your implementation? I find that one of the biggest challenges that organizations have to assess and address clinician burnout is lack of funding and staffing.
Yes. So here at AccessHealth, we have a total of 14 different locations. 8 of which are clinical, 6 of which are non-clinical that has like WIC offices. In terms of employees, we have around 300 employees that service we have about 20,000 plus patients over 2 counties. and that being Fort Bend and Waller counties here in Texas. So that's kind of the scope and scale of our organization. What was the second part? What's the second part?
The second part was how you funded your implementation, as funding and staffing were the biggest challenges in
Got
assessing
it.
and addressing burnout.
Well, part of it was advocacy. So, I really made the case with our CEO that this was really important, and if it was something important to our organization, that we needed to give time, as well as like monetary resource to that. So I was able to advocate for, I think we were given at that time $1,000 per month to kind of do interventions. That included like things within like trauma-informed care, human resources, as well as the well-being things that we were doing. So that's some additional dollars came from that. We partnered with our PCA that was able to get us in touch with that was able to kind of help us continue with that trauma-informed organizational transformation part, collaborative that we're a part of, but also to helped us link that partnership with the virtual mental health group that we ended up working with as well.
So it sounds like funding came from a few different places. And I think on a related note, we've got another question. Someone's saying that they found your comments on assessing partners outside staff very interesting. And how did you do that? How did you assess those partners?
Partners outside staff, like make sure I'm thinking about this correctly, like the mental health group I'm referring to, or is that kind of how that reads for you, Molly, as well?
Um,
Outside staff.
it may also be in reference to the PCA, the HCCN, the
PCA, okay,
university, but maybe that
got it.
individual can
That's
write back and clarify.
that may be it there. Let's see if they write back. Or-
Maybe just address any of those partners that you all
Okay,
sort of had to assess before moving forward with them.
for sure, for sure. So I was very fortunate. I live with a really amazing person who is my wife. She's also a physician. And she was that total worker health specialist I was telling you about. She's also doing her PhD within UT Health. So that's how that partnership really came about. And being that she was in the research department, there was a lot of contacts that we had there that were looking to kind of help with the COVID-19 pandemic at the time. But aside from that, I know that a lot of our community health centers already kind of have an academic partnership. So maybe reaching out and figuring out from leadership, where those partnerships exist, because they do oftentimes exist. So that was one piece of it. The primary care association piece of it was just right before the COVID-19 pandemic. My CEO has signed us up as an organization to be one of the people, a part of the second cohort through our primary care association, to have the community health centers in our state become trauma-informed organizations. And through that, I just developed a really good relationship with one of the coordinators who created the curriculum that really wanted us to like work together. So we fostered a really great relationship. And when the pandemic actually hit in the middle of, really at the beginning of our cohort, we were the only community health center that strongly considered continuing on with trauma-informed care at that time. And she really loved the idea of pivoting that training and content and education from just the patients to our employees. So they were just really willing to kind of help us with our demand at that time. And then the HCCN piece of it also came from their direct relationship as a PCA to the HCCN to provide funding to do the assessment for the entire state of Texas in the community health centers to assess. So it wasn't just for our community health center. It was the assessment was for all 73 community health centers within Texas.
Oh, okay. We just got the clarification. I don't know if you could address it very quickly, and then we're going to have to adjourn, but This,
Okay.
it was the comment about addressing, or assessing partners of the clinicians, like romantic partners, spouses,
No, so
about
we didn't
burnout.
no, so we didn't assess them. We just extended to them the ability to get free mental health services through the external partnership.
Okay, thank you. Glad we got that clarification. But I think it was still useful, how you answered the question.
Absolutely.
And okay, so that is all the time we have for Q&A, but thank you again so much, Dr. Daywalker, for your excellent presentation today, and for
Yeah.
everyone else who joined us and chimed in our polls and in the Q&A. I do want to put a plug in again for the resources that were on the previous slide, our guide and our infographic. You can find all of that on our publications page, and Josh can hopefully put a link there in the chat. And thank you again for attending the webinar. Thank you to our tech support team who helped make the webinar possible. Again, all the slides and related documents are on our webinar registration page and the publications page. Our next webinar is on April 24th. It's a continuation of our larger social determinants of health series, and it's going to focus on the social and community context. We'll have another alum of the NHSC present, Dr. Eileen Barrett. So we encourage current NHSC students, clinicians, and also leadership staff from NHSC approved sites to attend. So look out for an email with more details and registration info, and we would love to see you then. All right, thanks everyone. And Dr. Daywalker, if you have any parting words for folks, feel free to chime in one last time.
Well, really and truly, thank you guys for all of your time here spent with us, and the level of concern and appreciation that you guys have for wellness and well-being. And really just thank you guys for the work that you do within your communities.
All right, great note to end on. Thanks, everyone.